Thank you so much for the invitation. I really appreciate the opportunity to speak with you today. As John mentioned, I'm a professor at the University of Ottawa and lead the Canadian Health Workforce Network. And I want to situate myself in a couple of different ways. So thank you, Elder Cardinal, for acknowledging and opening up in a really good way. I think it's important that I identify myself as a settler. I grew up in Saskatchewan initially, near Muskeg Lake. There were about as many kids from Muskeg Lake as my school as possible. And thanks to Mrs. Arcan, I didn't realize at the time the huge privilege that I had in learning Cree in school. And Muskeg Lake is very near to Mistawasis, and the chief of Mistawasis, when they were negotiating their treaty, negotiated the medicine chest, and that was the main reason why Indigenous health services are provided by the federal government, by the Crown, in fact. And I think it's really important to recognize that the federal government does play a role in healthcare. It's often invisible, and I think that they could do a much better job at that. So we often acknowledge territory when we start our talks, and I want to make sure that that's not just performative, and also just to recognize that this is the 10th year, 10th anniversary of the Truth and Reconciliation Commission, with the wisdom that was provided to us in the calls to action, which includes calls to action 18 to 23, 23 being a really important one that I focus on as a settler, and that's to increase the complement of Indigenous health workers providing care to Indigenous communities, not exclusively, but primarily. And so these are calls to action that were provided to us, that were gifted to us, and it's really in the affirmation about 7 generations. So it's going to take us a long time to implement these. Nonetheless, we should get started and get moving on it. So I want to encourage us to explicitly keep in mind Indigenous health workforce issues when we're talking about rural and remote healthcare. So I found this sort of really nice innovation from a colleague of mine that said, if you only pay attention to one slide, this is the slide to pay attention to. This is essentially the talk in one slide. I'm going to try to make a case for rural health workforce planning. It requires understanding the unique, and I really appreciated Parliamentary Secretary Wiebe, the importance of equity. Equity is not equal. Rural and remote communities have unique circumstances in terms of population needs and workforce supply. And they have unique contexts, unique health contexts in terms of the types of issues that, farmers and those in forestry, those in oil and gas experience. There are different types of population health issues that they're experiencing. And also the organization of their health services. And there are culture in Indigenous communities, there's unique culture in rural and remote communities. This is a complex problem, but we have to start somewhere. I think about, peeling the layers of an onion. And so you have to kind of think about those different layers, an integrated set of solutions that include targeted recruitment, which is a distinctly different set of policies than retention. They're integrated. You need dedicated systems of support, more responsive, flexible, and context-specific models of care. So I really appreciated hearing that as part of the strategy. And the integration, explicit integration of mobile health professionals in a very mindful and thoughtful way. And again, the unique circumstances for Indigenous peoples as patients and providers needs to be considered explicitly in the development, spread, and scale of innovative solutions for rural and remote communities. The other way that I like to situate myself, and John failed to mention that, he let me to say that. So I grew up, I was born in Saskatchewan. I had my primary school there, but I moved to Manville, Alberta to do my secondary school. My brother still farms in Manville, Alberta. My mom is in care in Manville. My dad passed away and was in care in Vermilion. He had to travel to Lloydminster to get dialysis, which was a very interesting set of circumstances. I can talk about that later. And so I also, in addition to Growing up in a rural community, I do work at the University of Ottawa, but spent half of my time initially in rural Quebec and now in rural Ontario. Rural is very different. Rural Alberta is different from rural Western Quebec, which is different from rural Eastern Ontario, absolutely different. And so we need to kind of, I'm a sociologist, so context really matters, so you want to take that into consideration. So when we think about these layers of the onion, frameworks are really helpful to kind of figure out what those are. So I say it's important to start with a framework. Some people like a Donabedian framework, which talks about structures, processes, and the outcomes should be all across. So equity being very important, both to the processes and outcomes. These are part of the quintuple aim you probably heard, or the quadruple, the triple aim. There's now quintuple: equity, lower care costs, healthcare practitioner well-being. We have to support practitioners. We have to be mindful about population health and patient experience. And the processes is sort of around sort of the health workforce. There are processes around planning, processes around management of the health workforce, and how policy wraps around all of those. So there are inputs, activities, and outputs. So this was something that was adopted by the Canadian Academy of Health Sciences in its assessment that they did on Canada's health workforce. So let's get into some of the context. Again, you guys know this stuff, so I'll go through it rather quickly. I have some specific examples from Alberta. 1 in 5 Canadians live in a rural or remote community, according to Statistics Canada. They are widely dispersed across approximately 75% of Canada's land mass. Most of the population locates all across the border, that invisible straight line that someone mentions every now and then. But what's very important is you see in the red, which is very different than the yellow, which is different than the blue. So rural and remote mean quite distinctly different things. The demographic characteristics, ethnocultural fabric of rural and remote communities are quite diverse, and it reflects both Indigenous communities and waves of different types of immigrants. I mean, I grew up in sort of a Francophone area in Saskatchewan. Not my parents, but my parents' family came from Quebec. My mom, grew up in Peace River. The diversity of the population and service needs contributes to this complexity, so it needs to be taken into consideration explicitly in planning, and including, as was mentioned, equitable access to health care, employment opportunities, and I'm going to pick up on this issue of employment opportunities and infrastructure in a moment. So what's really great is Alberta provides data by rural and remote communities. This is not regularly produced by Pan-Canadian Health Organization, so I really appreciated having this graphic. So this is from 2020. So this is the percentage of health workforce practicing in rural Alberta. So you can see how low it is for physician specialists. That seems, logical because it's specialized services. You need to have a critical mass. And registered psychiatric nurses actually exceed, what is the average population. But the health practitioners, just like the population, differ both quantitatively in terms of the numbers and headcounts and FTEs, but also qualitatively. They're a different kind of stock, as we say. They possess a broader range of skills. Generalism is a skill set that's really important to valorize for rural and remote communities. And planning for rural health systems should be asset-based. You should take as a start who is there in the community, and then build out from there. So I'm very happy to say that work that I've been doing with Carolyn Chamberlain-Rowe, who now works with the Nova Scotia Health Authority, Sarah Simkin, who's a family practice anesthetist, we've been working together to develop a health workforce planning framework. Now, we have developed this in the City of Toronto, but in the same way that you build a house in the City of Toronto, you can build a house in rural Alberta. 2x4s are still the same. They're actually 1 3/4 by 3 3/4, but anyway, the 2x4s are the same, 4x8 sheets of drywall are the same. You just build it on a backsplit, side split, or however. The same standardized tools can be applied to different settings. So what we say is we have a fit-for-purpose process. You fit it for the purpose of the community. And planning can help align workforce with community needs. It has this cyclical process. You first of all say, what's coming up on the horizon? How do we plan? What are different scenarios, specific scenarios we should be integrating into this plan? And then, only then, do we put that into a quantitative model. Health workforce modeling is not health workforce planning. Planning is much broader than that. And then we develop policy based on what the analysis and the scenarios are saying, and then we do it again and again and again. And it's difficult to start a planning process. We don't do planning very well. It's difficult to start, but once you start, it's like pushing a rock. Once you get it started, it has momentum, and you should always keep going with that momentum. Start the data that you have. So the planning approach should be iterative, include horizon scanning, scenario generation, workforce analysis, which informs policy decision-making. Engagement with stakeholders should be embedded at each step of the process. You need to engage different types of stakeholders, not just the practitioners and the payers, but the patients and the public and caregivers and community leaders. They have to be part of that process. It should never be a black box done by health workforce modelers in the back room. That just doesn't work. You need to have buy-in, and you need to benefit from the intelligence of folks in the community. They have experiences that you need to provide to these planning processes. We've been doing this over the course, and we have learned a huge amount by doing this over 8 to 10 years in Toronto. There are different types of tools, again, standardized tools, fit for purpose for the community. It's not rocket science, but let's get started with that. Here are some of the questions that you can use to engage community members. From horizon scanning, like what are the pressures you're experiencing now? What are you thinking that's going to happen later? What are your priorities? What are you planning for? Are you planning for population growth, retirements, the lack of health workers in a particular community, a particular program, closing down? So the pressures are both on the workforce side and the population side. And out of all of those different pressures that you have, what are some key scenarios that you want to actually integrate into health workforce modeling? And then what you do is you gather the data for those scenarios and integrate that into the model. That's the only time that you should be starting with the data, is informed by these scenarios. Then you do the workforce analysis. What's the data that you have available? What's the data that you don't have? How do you leverage? How do you make those data available? And start with what you have. It's better than going by the seat of your pants. Even with bad information or incomplete information, just get started. And then out of that, you say, what are your options? And you can test those options in the model by saying, well, what if we did policy A? Oh, can we test it in the model and we see that makes it better? Okay, well, let's do that. Is there something else that we could do that would make it even better? Or if we did this, would that make it better or worse? So it helps you to inform which direction to go in. No one would ever set sail and never kind of course correct based on the evidence, the prevailing winds, etc. So that's about planning. Now, let's get into the management side of the health workforce. And because it's a unique context, there's a unique set of circumstances. And I'm going to draw heavily from a World Health Organization review that was done of all of the literature. And there has been a lot of literature produced on health workforce issues. Here are some of the key factors related to the decision to relocate, stay, or leave a rural area. A lot of it's personal. Personal needs to take into consideration, does this person have a background in that community? What is their whole life like? And you have to take gender into consideration. Most of the workforce are women, and so you have to understand that. Not to say they're exclusively, but even men have gender, and you have to take their gender into consideration as well, because it's not just their personal circumstances, it's their partner's circumstances. There are financial aspects, but not only. We can't incentivize ourselves out of this problem. It will not work. We do it around the world, and it hasn't worked. So we need to stop investing only in financial incentives. There are working and living conditions. That is critically important. And a lot of it is housing in rural and remote communities. We heard that a lot. Mandatory service is a possibility, but again, if you're using sticks instead of carrots, it has a subtle message to folks. And again, if you're focusing on incentivizing practitioners who grew up in an urban area to work in a rural area, it's not a long-term solution for that. There's career and education related. That's really important, and I'm going to go on the next slide to some key indicators about that. Family and community, very, very important. Again, you have to think of health workers as whole people with families and connections that they have. So I'm going to come back to the career and education related opportunities. So out of the entire review, and this was extensive and tons of literature was reviewed from many, many different countries, from Australia to the United States to, Russia and Finland, just everywhere. This is the only recommendation for which there was moderate certainty of evidence. The only recommendation. The first recommendation, enroll students with a rural background in health worker education programs. That's your biggest return on investment. And I stand here, someone who grew up and went to high school in Manville, Alberta, had a graduating class, and it was a big graduating class, for that particular year, of 25 students, And I managed to get to where I am. And there are brilliant people in rural communities, young people in communities, that we need to invest in them, in their training, and not just for the health workforce, but the teaching workforce, the legal workforce. We need to invest in our rural communities, and that is what they said, targeted admissions to enroll students with a rural background. So that's a multi-pronged strategy in and of itself. Now let me speak specifically to Indigenous communities. If we would invest in the education of Indigenous communities, this would be a triple win. We would have more Indigenous workers per se, we would have more Indigenous health workers for Indigenous communities. That's a triple win program. You get triple your investment from investing in health and education training in Indigenous communities. So I really, really want to highlight this. Out of the many, many recommendations, this was the most important one. In our Canadian Academy of Health Sciences review, we talked about 4 leading practices, and I was really pleased to see many of these reflected in the rural strategy, so that's really great. First, promoting processes for targeted and facilitated admission, positive rural and remote exposure for those healthcare practitioners who haven't grown up in rural communities but have an affinity, and distributed practice-based learning opportunities. And this is inclusive of medicine, but it's not exclusively for medicine. We need to think about, for example, how from the get-go, training for midwifery in Ontario, I believe also in Alberta, is located in community. Look at how some of these training programs operate. Paramedicine programs, pharmacy programs can also have much more distributed learning opportunities. So when you're looking at this, think a whole of the health workforce approach to that. 2, encouraging healthcare practitioners' retention and support through effective incentives, that's not only financial, practice-based supports and community integration. 3, creating, and I was pleased to see that, creating more responsive, flexible, and context-specific models of care. There's no one-size-fits-all for urban areas, nor is there one-size-fits-all for rural and remote communities. This needs to include an explicit interprofessional focus, focused on who is there. Team-based care, enabling practitioners to adjust their scope and skill set to better meet the needs of their community, and giving them tools to really identify what those needs are. Now, I was also really privileged to be part of a co-lead for the Team Primary Care Initiative. There were a whole range of tools that were developed to really scale up the way that health practitioners can work together. Registered nurses, in primary care, lots of programs around pharmacy. There was an entire program led by the Indigenous Primary Health Care Coalition in Ontario to really integrate community-based practitioners based on Indigenous knowledge needs. And then enabling the mobility of healthcare practitioners with unique aptitude and training for rural and remote practice. And this builds off the rural roadmap that the College of Family Physicians did. There are particular times in one's professional life where you're not tethered yet. Early life, later life. And how do we create those opportunities? They're quite distinctly different. So really think about that through these different types of locum reliefs. More appropriate models of care for rural and remote communities, expanded roles, working to top a skill set, really valorizing generalism as a unique skill set and not just a little bit of everything. There's something like value add, there's something on top of that than just, it's more than the sum of the parts, I guess is what I'm trying to say. Providing culturally safe, virtually enabled care, which may positively impact ongoing work through task shifting that can happen between urban and rural practitioners to help address the inequities that we see. But we need to recognize the limitations of digital connectivity. When I drive from my place in Ottawa to my place in now Plevna, North Frontenac, there are a whole bunch of places, and we're in southwestern Ontario, which should be the most connected place, tons of pockets where you don't have connectivity. And so that's exacerbated more broadly. So policies and practice that enable the mobility of practitioners, again, that we mentioned before. I want to mention a case study of Hinton, Alberta. I was asked to comment on this back in June of 2024. For some reason, I think media in Alberta know that I'm initially from Alberta, and they reach out and contact me. They said, Dr. Bourgeault, what's your opinion on what's happening in Hinton, Alberta? And I was like, well, a couple of things. First of all, it highlights that municipalities are also part of the solution, and municipal governments have a role to play, just like the provincial government and regions within it, and the federal government has to play. So what they had was a problem where they had the exodus of so many family physicians, and it left those who were remaining having to pay for this entire clinic. And so they decided at the community council to pay for the clinic, which I thought was good on them, you know, for stepping up and doing something. What I had suggested, and actually spent time going through the community directory in Hinton, for no cost, by the way, I just do this stuff for free, and I looked at all of the practitioners who had their independent clinics, the physiotherapists, the massage therapists, the paramedicine, like all of these different types of practitioners who could have been co-located in this clinic. And co-location is a start to actually getting to work together. So it was good on them for doing something. They could have went a little bit further to be a bit more audacious to really kind of focus on team-based care. So these were the main recommendations that, again, came out of our Canadian Academy of Health Sciences report. There's a distinct chapter on rural and remote you can download for free. Targeted and facilitated admissions, positive exposure of healthcare practitioners, practice-based learning, incentivized recruitment retention, integration, and an open access network of models of care. These would be really helpful. And Canada is also part of this international partnership, Making It Work framework for rural workforce stability. And when I presented this, to folks in Europe earlier, they mentioned how in many of their countries they were working on this, and they really appreciated the Canadian contributions to that. We need to spread and scale those innovations happening in Canada within Canada. It's great for Denmark to find out about this, but we should all find out about this, So my key takeaways here, and I really want to engage with you in this conversation. I feel I have some solutions to bring to the table. I don't have all of the answers, and the answers come from the dialogue that I want us to have today. First and foremost, I hope that I've made a case for planning. Planning is critically important, it's undervalued, and it is a huge return on investment. It would benefit from community engagement. You really do bring everybody to the table, and they get buy-in for this. And so you have people who are valorizing and champions for this, rather than people who are going to go to the media and criticize it. That's a really important thing. So better understanding the unique population needs, healthcare utilization, and how this is affected by the supply of health workers. You need to generate context-specific scenarios that make sense, fit for purpose, using standardized tools and standardized data where available, but again, make it fit for purpose based on these promising and more appropriate models of care for rural and remote communities, as well as support and retention initiatives. All of these things, if you go back to the framework, your planning is improved if you link your deployment, your policy analysis, those decisions that you're going to make on a foundational planning process. And local capacity building and planning explicitly recognizing principles of Indigenous workforce issues, Indigenous data sovereignty, and healthcare governance should be co-developed. Everything that we do is co-developed. Does it take longer? Yes. Is it better? Much, much better. So I really would like to thank you for that opportunity, that privilege to engage with you, and I'm really looking forward to the conversation. So thanks so much.
Thank you very much, Ivy. And actually, maybe if you want to you can take a seat here. We do have, in Glasswater, we do have a reflection panel that we've gathered of people to make some preliminary comments, and then open up to individuals here in the particular room, and we'll maybe have some time for questions online. And we've got a great reflective panel, which we hope can be an interesting, imagine we're at a late night talk show, and this is our interesting guests who we have here involved. But first is Dr. Jill Conkin, who's a physician and long time through her career serving marginalized community and rural health care, and has been really committed. She's with the Faculty of Medicine and Dentistry at the University of Alberta. Alison Ross, who is beside her. Alison Ross is a nurse practitioner with a long experience of nursing and leadership roles. She actually is Executive Director for Chronic Disease Management for Alberta Health Services, and she did sit on the Modernizing Alberta's Primary Care System as an advisory member of that panel, which has developed the approaches for moving forward on developing Primary Care Alberta and an infrastructure to support movement in that area. And then we have Stephen Samus, longtime colleague, but Stephen wears two hats, one as a former deputy minister of the Yukon, dealing with a lot of remote and rural and remote communities in service, but Stephen also serves as the chair of the Imagine Citizens Network for the province of Alberta, which brings patient groups and tries to develop citizen and patient input into the work in all sorts of sectors of the health system. And just recently, he's sitting on the Alberta Blue Cross board, actually. But so first of all, what I'm going to just pass through, and there's some mics on the table, actually, if perhaps I'll start with Stephen, perhaps, and provide some reflections and comments and questions for Ivy. But just for some quick reflections from your point of view of what you'd heard from Ivy's presentation.
We're on? Okay. Thank you so much, Ivy. It was really interesting to hear your presentation, and both the summary of the literature. I found it very interesting to see what was really the most and really the only evidence-based strategy that came out of that international review. Very, very interesting. But I wanted to just ask you a question, if I could, because I really appreciated that you started off by talking about the Truth and Reconciliation and the final report, and particularly Call to Action 23, which is around expanding the Indigenous workforce in the health sector. And so 10 years on from the TRC, how are we doing in that regard? Can you give us a sense of, is that actually improving? Are we seeing more Indigenous recruitment and retention in the health workforce? And what do we need to be doing to accelerate that?
Great. Well, let me speak to that last question first. Yes, in every talk that I present and whenever I do an Indigenous affirmation, I remind everybody that it's our work as settlers to implement the calls to action. And it's 10 years on. That doesn't mean that it's out of date. No. It is very, very au courant. How are we doing? It's hard to actually answer that question because most jurisdictions do not collect data on Indigenous identity of their health workers, nor do they recognize unique Indigenous health worker cadres. And there are many, right? There are not just Indigenous health workers, generically speaking. So, in Australia, they do regulate, Aboriginal and Torres Strait Island practitioners. We do not have unique regulated categories for Indigenous health workers in Canada. The only slight exception is to allow Indigenous midwives. So there's a carve-out in the legislation in Ontario to allow Indigenous midwives who train in community to be able to practice in community without having to be a registered midwife. And midwifery has undertaken a lot of explicit training in that regard to integrate more Indigenous practitioners. So there are some registered midwives who are Indigenous, and there are some Indigenous midwives who are not registered midwives. And so I think it would be really important to kind of look at, some of those different opportunities. Part of the complexity of counting who Indigenous health workers are is respecting Indigenous data sovereignty. So, and this is not just, for First Nations, but for Inuit and Métis. There's a First Nations Information Governance Center that talks about OCAP principles, ownership, control, access, proprietary. I think those are the OCAP. And we need to ensure that there's infrastructure for Indigenous communities to collect, confirm, right? Because we have a lot of people who self-identify as Indigenous who may not be Indigenous. So collecting, confirming, and producing knowledge based on the data in partnership with Indigenous health workers. And I'm happy that Alika will be joining us because we've had a dialogue about this, and moving towards having greater infrastructure. And I know, for example, the Canadian Institute of Health Information is in dialogue with different Indigenous partners. So if you don't count, you don't know if you're doing something better now than you did before. So there's some complexity to being able to answer that question. My sense of it is that there's more visibility of Indigenous practitioners. There are more routes into training for Indigenous practitioners. And there are many more Indigenous health practitioner organizations, Canadian Indigenous Nurses Association being like the longest standing one, like from 1974, Indigenous Physicians Association of Canada, National Council of Indigenous Midwives. There's groups for Indigenous pharmacy professionals, that includes the technicians and pharmacists, as well as Indigenous pharmacists, Indigenous herbalists, so they're quite inclusive. And dentistry as well. I just want to close off with the sort of the international review evidence. There was lower quality of evidence for many other recommendations, and they still made those recommendations. This was their first recommendation that had the strongest evidence, and it is the one that I really want us to think about because it has many dividends to focus on rural workforce development.
Okay, thanks very much. And well, actually, I'll just interrupt our reflective panel because Elder Cardinal, I think, had a question. Okay.
Thank you for the work that you are doing, and I saw some changes in there. But the one thing is, my brother had got hurt, and he had polio when he was a child, and so he ended up in the hospital, and he had to have surgery. But when we went to visit him, we noticed that what he wants is more, or what I want also, and Indigenous people, is to have more male in the hospital to help the male, because he was shy because they just kind of like flipped the sheet over, and here my sister and I are sitting there, and I said, whoa, so I went and covered him back, because for us, we don't show off our body. And so I prayed about it, and I said, I would like to, who do I talk to? Who do I go and see? Because I remember the last time there was some kind of, a few years ago, and I did bring it up where the women don't like to be stripped naked in a change room or something, like get a curtain, get a gown or something if the doctor's going to come in and see them, male or female. But they have made those changes. but now I'd like to see more male, to help the male in the hospital.
Absolutely, absolutely. I 100% agree with you. My chair is in gender diversity in the professions, and we have to get more men in certain cadres of the professions, right? It has evened out in terms of women in medicine, in dentistry, in pharmacy. But, I can count on my hand how many men there are in midwifery. I can count on my hand how many men there are in dental assistant, dental hygiene. Like, it's very, very small. I mean, there are a huge amount of nurses, but we still have seen a persistent gender imbalance, and it's absolutely necessary. Registered psychiatric nurses, I think that there's a better gender balance, but still overwhelmingly women. And so we absolutely need to do that.
Thanks. Allison, if you had some quick reflections and comments.
So I guess I have a lot of thoughts. I really appreciated your look at the factors that affect the recruitment and retention of health workers. We've seen that in the North, mostly with our internationally educated nursing folks who've come to small communities from other countries and don't have a community there. And they are always the ones that leave first. Those that have an existing community within the community that they're coming to are far more likely to stay. How do we create that same community for our rural workforce that we're going to invest in to encourage them to go back to rural if they don't want to go back to their own community?
That's very good. There are there's a few layers there. I'm going to start first with, yes, I don't live in Manville, Alberta anymore. Yes, I mean, it's very difficult for me to be a professor in Manville, Alberta. So yes, there are people who leave community. And that's where you would want to try to figure out, I mean, I go back regularly. I mean, I'm not a healthcare practitioner, but if I were, then that would be a wonderful opportunity. And in fact, like in Nova Scotia, they're trying to create, ease of licensure for, rural physicians who want to go back and summer in Nova Scotia or summer in PEI so that they can practice, and it's kind of a locum. I think that those are really good ideas for people who have left, and maybe they won't want to come back full-time, but think about how they might come back in parts. Right? I think that we need to be a little bit more innovative in terms of like job sharing and that sort of thing. I think we and many other countries use internationally educated health practitioners to solve our crises, and our crisis in rural care, that's physicians, that's internationally educated nurses, is problematic. And I know this from, folks who have migrated from India or working in Nova Scotia, Philippines, and pretty much all of the prairies. And they are enormously isolated. And I've done a lot of work and have gone to South Africa and Philippines and India. Went to a classroom in India where they were studying from Canadian textbooks. You ask them who wants to migrate to India. This is in the Punjab. And every single one of them put up their hands and they were coming here. So there's a whole broader international dynamic going on there. But if we just look at the rural lens, I would, and we need to do this as well for Indigenous health workers, you can't just hire or have in your training program one Indigenous student or one Indigenous practitioner. I have been in circumstances where I'm the only woman, in a class or in a room. That's not a comfortable place to be, and I don't think that would be comfortable for anybody here. So we should never create those circumstances. So when you recruit a cadre of people that come together. Not to say that they're all going to agree with each other, but at least there's some sense of community. They did that in a long-term care facility in Nova Scotia. They recruited a cadre of folks from India, both men and women. So that was really great to see, that there was a nice gender balance there. And I think that is a strategy that works better for both the sustainability of the worker and the sustainability of the worker in the community. Yeah.
Hey, thanks very much. And Jill, if you had a kind of a quick comment and then a question.
So thank you, Ivy, for a wonderful presentation. I liked your frameworks. But my question is, at the moment, I've been involved in rural medical practice for 40 years in this province and in rural medical education for 20. I would say this is the worst it's ever been as far as workforce goes, that it's a crisis. All of the things you identified take time. So if one looks at admissions, we admit somebody this year, it's going to be at least 6 years before we know what they're going to be doing if they become a family dog. And then another 5 years. We just did a study that showed that the majority of docs who set up in rural practice in Alberta, and this includes IMGs, international medical graduates, as well as Canadian, leave by the end of 5 years. And so if we don't get something happening now, we're going to have no communities that are going to be able to do the medical education to make the workforce for the future. So what do we do in the meantime?
Absolutely. Thank you for asking that, because it really is an important issue. I think that we need to take short, medium, and long-term solutions. The importance of when you engage stakeholders in a community around planning, you can also engage with them about what are some short-term solutions that they can work on. What are ways that people can, relieve a house, or a room in a house, or some type of support. Engaging the community in this means that everybody's bringing some solutions to the table. So yes, I think that you have to identify short, immediate solutions that help. Short, medium, and long-term. What we do in Canada is we go from short to short to short to short. We're always working in crisis with no time ever presented to long-term planning. There's a slide that my colleague who does a lot of work in rural North Carolina, Erin Freyer, and she has a slide that talks about these waves. If you think about a chart with an X and Y axis in these waves, that we go from surpluses to shortage and surpluses to shortages, or supposed, because there's no standard definition of what is a shortage and a surplus. Shortages are usually we don't have enough money for everybody. But we're definitely in a shortage situation. And if we had done some planning, we could have anticipated that these would be coming. Now, so the best time to have planned would have been 5, 10, 20 years ago. The next best time is right now, is today, is get started. And you can use the engagement process for planning to identify short-term solutions, some medium-term solutions. I would say probably in a medium-term solution is what the example that I used with Hinton. They had a crisis, they solved it with money, but that was not going to yield a long-term solution. And I don't know that my co-location experiment would have worked much better, but at least it would have been something. And it might have generated really bright-minded people working together to figure out solutions. We have, in healthcare, we don't have these exclusive scopes of practice. There are absolutely some things that family physicians do that others don't do, that nurse practitioners do that pharmacists don't do, and midwives, and all of the different practitioners. But my understanding, and again, I'm not a clinician, so please forgive me, but my understanding is about the main presentations in primary care are mental health and substance use health and musculoskeletal issues. I'm suffering from my own musculoskeletal issues from moving, but those are two main conditions. How is it that we can bring in practitioners who have spent dedicated 4 to 6 years just on those topics? So there's a lot of really brilliant folks who, and here's again the other thing from an investment of public resources. We invest in the training, not just of physicians and nurses and midwives and pharmacists, but physiotherapists and occupational therapists and dietitians and psychologists. We invest in their training publicly. Yes, everybody pays tuition fees and they have student loans to pay, but we invest in them as well. Now, as a public, when we invest in practitioners that we do not get to access other than through our private health insurance, that is not a good return on our investment. So it's not a good return on our investment. It doesn't enable all of those brilliant skills to be integrated in the system, and we overuse other practitioners. Is there a way that in the medium term that we can work together to support that? And again, yes, there is going to be some education and training that is going to be required. Coming out of the Team Primary Care Initiative, my main takeaway as a non-clinician is that not one educational and training program in this country integrates what all of the other health practitioners do. So in a medicine program, you find out what the nurses do by your placements, but you don't have a training program. You don't have like curriculum that says nurses have been regulated. There are nurse practitioners, which are distinctly different from psychiatric nurses, from registered nurses, from practical nurses. Practical nurses are not psychiatric nurses, even though there's a P in their name, right? And forget, knowing what pharmacists know or don't know, what optometrists could or could not do in your community. I think that that's a medium-term solution that we can start really shoring up folks that we have while we do the longer-term planning.
Yeah, and thanks. Just for a couple of questions, but Stephen had another question, actually, that he wanted to ask you, Ivy.
Thanks, John. Ivy, one of the things I was really interested in was you talked about aligning the fit-for-purpose workforce with community needs, and you talked about the establishment and the nurturing of workers, community health workers in communities. So when I was up in the Yukon, we had a government-mandated review of our health and social services, and it resulted in a report called Putting People First. And one of the recommendations in that report was, and there have been many other reports that have talked about this, but in remote communities, and particularly in Indigenous communities, developing community health workers who are of and for the community. They're from the community, they are in the community. They may not have formal education, but they have a tailored, fit-for-purpose education that enables them to stay in their communities, be part of their communities, and be active in improving the health of their communities. And then a role that government can play in that is to help to identify some advancement ladders for those community health workers so that they can progress and remain in their communities and stay there. So it's not about going off to university somewhere and coming back to your community. It's about being an identified resource in your community who can enable the health of your community. Have you seen that take root in a number of places that you could
Well,
shed some light on?
they take root, but the roots are not deep. Again, forgive the farming analogies. So yes, community health workers are a cadre of worker that we could better utilize here. They do in the United States. They do pretty much in every other country. We seem to be quite exceptional in that we don't. We do integrate sort of like cultural health brokers, and these are typically internationally educated practitioners, whether they're physicians or pharmacists, physiotherapists. So we've produced, the Team Primary Care has produced a compendium of roles in primary care, and so there's an entry in there on community health workers and cultural health brokers. I will mention the Educational Upgrade Program in Nunavut, which is now defunct. It was developed by two IMGs, and I believe they were from Ghana. So this is such a brilliant transfer of an innovation from south to north. So the Educational Upgrade Program in Nunavut, what they did is they chose people in the community, or the community actually identified people who would want to take on this training. Some of them were men, some of them were women, had children or no children, and they were given whatever resources that they needed to develop this program. Is it a computer, a laptop computer that they needed? Did they need internet access? Because all the training happened in community. Did they need childcare? And childcare, again, because you're looking at communities where people know each other, that was fine for them to actually provide support for their mom to take care of their kids. And they developed, it was all as part of a kind of laddering approach where you develop community health workers, and then if people wanted to go on in a public health stream, they would go on into a public health stream, or if people wanted to go into a nursing stream, and they were talking about connections with the Northern Ontario School of Medicine and Laurentian University, some would go on into midwifery, but they all started as community health workers. And they do this program quite well, I wouldn't say extensively, but it has gained a foothold in the Philippines. They do that because most of the Western trained Filipino workers migrate out. I mean, that's largely why they go into these programs, is to migrate. And so they've had to create a Made in Philippines program to keep Philippines worker there. And so that is this educational upgrade program. If you're interested in that, I can put you in touch with the people who generated the program, Victor Akande and Timothy, I can't remember Timothy's last name. But this has happened and was working. That's it. Again, people moved from community and they weren't able to continue, but it's very much a promising practice that should be spread and scaled.
Thanks very much. And we're just going to move on now because we have time for a collective discussion around everyone else, and I'm sure questions will be able to pose to Ivy. But before the break, we just had presentations of one from Alberta and British Columbia. But please join me in thanking Ivy, who arrived at about 3 o'clock in the morning last night, and so I think she's done very well today in presenting. But please join me in thanking Dr. Bourgeault.